So good morning, everyone. I would like to present my 3 months progress on my PhD topic, which is investigating the different etiologic factors of preterm birth. My name is Eszter Hoffmann, and I work as a resident doctor in the Department of Obstetrics and Gynecology in Semmelweis University. My supervisors are Csaba Demendi and Nándor Ács. My vision is to contribute to the prevention of preterm birth, and my mission is improving the protocol for treatment and prevention of vaginal infection during pregnancy. I have 3 ongoing projects. The first is a meta-analysis, which investigates the efficacy of screening of vaginal flora during pregnancy. The second one is a meta-analysis, which investigates the efficacy of the treatment of abnormal vaginal flora during pregnancy. And the third one is a genetic study, which investigates genetic variation associated with preterm birth. First, let me talk about my first project. Its title is Investigating the Efficacy of Regular Screening of Vaginal Flora During Pregnancy to Reduce the Rate of Preterm Birth and Premature Rupture of Membranes. The background of this topic is that the incidence of preterm births in Hungary is 7.5%. And the cost of the 6 months hospital care for the neonates is almost 8 billion forints. And the common cause of preterm birth is infection. And during the pregnancy care, we don't have exact protocols for screening vaginal infections. And our aim to see if routine screening of vaginal infection could prevent preterm birth. Our clinical question is that can regular screening of vaginal flora during pregnancy decrease the rate of preterm birth and premature rupture of membranes? Our population is pregnant women, and the intervention is screening of the vaginal flora. The comparison is no screening, and the outcomes are preterm birth, premature rupture of membranes, and the risk factors of preterm birth. And our hypothesis is that the regular screening of vaginal flora can reduce the rate of preterm birth. And our clinical implication is to decrease the rate of preterm birth by updating pregnancy care protocols. We did the systematic search on the 21st of October, and now we are in the phase of data extraction from these 34 eligible articles, and we are planning to finish it by the end of next week. And now let me talk about my second project, which is a meta-analysis that investigates the efficacy of treatment of abnormal vaginal flora during pregnancy to reduce the rate of preterm birth and premature rupture of membranes. If we have enough data in this study, we would like to do a network meta-analysis. As we talk about the background of this topic, I would like to say that a common cause of preterm birth is infection, and there is no guideline for managing vaginal infection during the pregnancy. And if we talk about the treatment, we can use many kinds of treatments. We can use oral or local treatment. We can use antibiotics like clindamycin or metronidazole. We can use probiotics, we can use lactic acid or clotrimazole, or we can say that we do not treat the vaginal infection at all. And our aim is to see if the treatment of abnormal vaginal flora can reduce the rate of preterm birth. And our clinical question is that can the treatment of abnormal vaginal flora during pregnancy decrease the rate of preterm birth and premature rupture of membranes, and which is the best treatment? And our population is pregnant women. Intervention is the treatment of abnormal vaginal flora, which can be antibiotics, probiotics, as I mentioned, many kinds of treatments. The comparison is no treatment, and the outcomes are preterm birth, premature rupture of membranes, and risk factors of preterm birth. And our hypothesis is that treatment of abnormal vaginal flora can reduce the rate of preterm birth. And the clinical implication is to decrease the rate of preterm birth by updating protocols for the treatment of abnormal vaginal flora. We did the systematic search on the 21st of October, and we finished the title and abstract selection of the articles, and we have 321 eligible articles, and we would like to finish the full text selection next week. And let me introduce you our third project, which is a genetic study, and its title is Genetic Variation Associated with Preterm Birth. The background of this topic is that the etiology of preterm birth is variable, and aggregation of spontaneous preterm births in certain families suggests that there are underlying genetic factors. and both maternal and fetal genomes likely affect susceptibility. And the different genes can be associated with preterm birth, but more examination is needed according to the literature. And during our preliminary research in the literature, we found that the genes predisposing to preterm birth often overlap with genes predisposing to various inflammatory diseases. And inflammation is one of the known causes of preterm birth. Here in this chart, you can see the genes that were examined and the overlap with Crohn's disease, ulcerative colitis, periodontal disease, and the preterm birth and premature rupture of membranes. We chose the DFB1 and MBL2 genes to be examined, and our aim is to identify fetal genetic variants that predispose infants to preterm birth. And our plan is to examine the placentas that were collected from pregnancies that were combined with intrauterine growth retardation, preterm birth, and we have a control group as well. We have 400 placenta samples, and we have a database with the data from all of the pregnant women whose placenta was collected. And we are planning to examine the two genes that I mentioned, the MBL2 and the DFB1. And these genes are associated with inflammation and preterm birth. As a summary, I would like to say that we would like to submit our 2 meta-analyses until May in 2022, and we would like to submit our third project in the first part of 2023. And to close my presentation, I would like to share the quote of my favorite basketball player who said that everything negative, pressure or challenges is all an opportunity for me to rise. Thank you for your attention.
Hi, I'm Balázs Komorúci. I'm a resident at Obstetrics and Gynecology. I'm just wondering, by listening to you, that if it is well known that vaginal infection can lead to preterm birth, what can be the explanation? There is no screening for it during pregnancy. Can you explain it, please?
Yes, thank you for your question. During pregnancy, if we have asymptomatic vaginal infection, then we don't have a routine screening protocol for that.
Thank you. I'm Dr. Kopány Kocsis. I'm an orthopedic traumatology surgeon. I'm interested in, you told that the prevalence of preterm births here in Hungary is about between 7 and 8%.
Yes.
And could you tell us what's up with in Europe, in the other countries? Is it high or low level?
It's in the middle, and worldwide incidence of preterm birth is 12%.
Thank you.
And if you'd like to be surprised, it's much higher in the United States, for example.
The first study and the second, I mean the first and the second, actually very, very similar.
Yes.
Do you get the same, just looking at this, that's not obvious whether you catch the same papers or different ones. So please tell us a little bit about the difference between those two, because you will also be criticized, when you write your paper, that why didn't you go for that? Okay, say something and then I will ask some more specific.
Okay, we found papers and studies that were examining the utility of screening, and they had a flowchart that they had a control group which had no screening at all during the pregnancy for the vaginal infection, and they had an intervention group which had screening for vaginal infection, and of course if they found something, they could treat that. But in other papers, we found that...
Yeah, but that also means that if somebody is screened, then probably some treatment actually follows. So, and then it goes to your next meta-analysis, and I just try to see the overlap, because probably in your second meta-analysis, when somebody gets treatment, he gets treatment because there was some identification of the problem. So then what is the difference between the two studies?
The difference is that if we don't screen at all, we don't have the chance to treat it, of course, and most of the infections are asymptomatic. So that's why if we see that there is an infection, we can choose that probably we treat a group or we don't treat because it's asymptomatic.
If I may add something from the obstetrician's point of view, these are really two clear clinical questions in obstetrics and gynecology. We have very strong data on the other side, on one side, that screening may be really very useful and helpful in reducing the rate of preterm birth. But on the other side, on the other hand, we have a lot of investigations from all over the world saying just there's no use for screening. So the first question is whether it's worth to screen, and then if we screen, the other question is, it's also not clear whether we find any vaginal infection, whether we should treat that or not. Is there any benefit of treating, or you just pose the infants to any harm with this treatment method? So it's really these are really two clinical questions.
Sorry, I'm Balázs Linter. I'm the supervisor of István Baradács. Just one question regarding the third topic. Do you think, or do you have any information, is there any clinical relevance or recommendation if you know the genetic background?
Probably we can screen the mothers and the pregnancies for these genetic variants, and we can get ready for a preterm birth.